Good morning, everyone. Welcome to the patient error prediction tutorial. Let me start by saying that I hope that you really enjoyed what we did yesterday with patient error prediction, that we started with a question in the morning and went all the way to the end and actually doing external validation of models. What is nice about this tutorial is that you will now learn what actually happened behind the scenes and why we were able to build these models in such a short time period and why we were able to do external validation. That would not have been possible with the OMO common data model in place, but also having our patient error prediction framework out there is, of course, a prerequisite for that. Let me start by introducing to you the faculty. So I'm Peter, I'm from the Erasmus Medical Center. We have Jenna, you've seen yesterday on the stage as our star, and Patrick, you also seen, and Ross, Williams, and Chan, who's in the back and just got the award. I like to start actually all my OHDSI presentations with the mission of OHDSI, because I think it's important that we keep realizing why we are actually doing all this work and why we are doing all this nice data science. In the end, it's really to improve healthcare. Although we do like, as data scientists, to play around with our algorithms, it should in the end help the patient. Why I also really like the mission is that it's about empowering a community, and that's what we also try to do in the patient error prediction framework. We like to get people involved in building the framework and expanding that over time. And of course, use the community to run that the algorithms across the data network. In that sense, all the work that we are doing in OHDSI is about the patient journey. So a patient will generate different events during its lifetime. So it can have a certain disease that happens, a treatment that happens, all kind of artifacts are happening, all kind of measurements and procedures. And what we normally want to do is we want to look at the time zero, somewhere in that patient journey. We want to look at things that happened in the back, and we want to say something about the future. What's important to realize is that all those patient journeys are incomplete. We don't have all the available data in our electronic health records. And it's important that each patient has its own journey through life, and we like to utilize all the available data for our questions. There are different types of questions that we can answer on that journey. Things like, which treatment did patient choose after a diagnosis, or which patient choose which treatment, etc. These are more like data characterization questions. We also have the patient error prediction question: what's the probability that I will develop a disease using all my available data? Or what's the probability that I will experience the outcome? Other questions are more risk effect estimation questions, and like the legends story that you heard yesterday: does treatment A cause an outcome more than a treatment B, etc. These type of questions are outside of our scope here. We really focus on the prediction question. Clinical observation is more, clinical characterization is more about observing data. We like to do inference here, and what Martijn and Mark showed yesterday is causal inference, where you really do risk effect estimation. We focus on inference. The agenda of today starts actually with the thing that we did yesterday, asking a question. You have to think about a clinical question. Then I will give you some background on patient error prediction, what it is, and also what it's not. And then we will go through the framework. Jenna will go through all the functions and all the functionality that we have in the framework, and you will be playing with it yourself as well on the virtual machines that were made available by Amazon. Then after lunch, we will look in the tripod statement, which is a very important statement that tells us how we should report our prediction models. And we will go through the CHATS2 paper that I hope you have read before coming here, because we will go in depth in that paper, and you have to do some exercises on the paper as well. And then we will be implementing the CHATS2 in our framework and running that on a data set, and you will be able to implement your own prediction problem. So let's start by selection of prediction problem, and that's something that Patrick will do.
So Chan and I want you guys to start with an exercise. We hope that starting with you thinking about a question is going to actually help motivate you as you're learning about examples of other types of questions to be thinking about your own question and how you could actually be starting to generate evidence and improve healthcare for questions that actually matter to you. And so the exercise that we're going to go through is what you got to do very quickly on the screen yesterday, but we're going to take a few moments to think more critically about the steps of coming up with a good prediction question. So you saw this picture yesterday, but when we frame a prediction problem, what we are thinking about is defining a target population. That target population, we have to have some sort of an index date, which is when is that moment that you are going to predict something for a given individual. And on the basis of that moment, we can use all of the information we know about a person before and on that day to try to predict anything that's going to happen to that person in the future. And so when we think about our prediction problem, you heard from Jenna that we want to talk about instantiating a target cohort. So that's the population of people who you want to predict for. We're also going to separately want to create an outcome cohort. So those are the events that we want to look for. And we're going to want to define a time at risk, which is going to be the period of time, some duration after when someone has entered the target cohort, for which you're going to look to see whether or not a person had an outcome. The other component that you're going to learn a lot about in today's class is model development. So which algorithms should we apply and which features should we construct? But for it's important to recognize that there are a lot of different algorithms that are available and at your disposal. But it all really starts first with an important clinical question that matters. So,
do you mind if I ask a question?
Please, go ahead.
Just to clarify on the previous, and I also noted that yesterday. So this term cohort, in epidemiology, we usually learn that for the first definition, I think, a target cohort, so you define a group of patients or group of participants and you follow them over time. We also use this term for outcome. Is that a technical reason merely, or can you explain a bit?
Yeah, and we do go through it in the more extended. Yeah. So I'll allude to it briefly now, but you'll get a more extended conversation as Peter goes through. But yes, very explicitly, what we are doing is we are defining every object as a cohort. A cohort has a formalized definition in our OHDSI ecosystem. So it's a set of people who satisfy one or more criteria for a duration of time. And so under that definition, you could imagine that the people at risk are a cohort at the moment they become at risk. We deliberately separate time at risk from the cohort definition because one could be in a cohort for some reason that's independent from the prediction problem. To provide a very specific example, you might have a cohort of people who are, our problem yesterday, people who are exposed to anticoagulants. In which case, you would enter the cohort when you start being exposed to an anticoagulant. You would leave the cohort when you stopped taking the drug. However, time at risk, we might say all time following the initiation of therapy. So time at risk is different from the cohort of anticoagulant use. Now separately, the outcome we might be interested in might be something like ischemic stroke or hemorrhagic stroke, as we did yesterday. In which case, it is reasonable to create a cohort of hemorrhagic stroke episodes where you enter the cohort of hemorrhagic stroke at the time you had the event, and maybe you leave that cohort once the stroke has resolved, or potentially in certain diseases, if it's a chronic kind of an ailment, once you qualified for the cohort, you are in there forever. By creating independent cohorts, there's a lot of advantages that we actually are able to build into this, but one of the most prominent ones is by breaking up the pieces, you don't make conditional choices about, for example, the definition of your outcome conditioned on your target cohort. Rather, we can independently say, let's define our target cohort as people who are on anticoagulants. Let's separately find our cohort of people who had hemorrhagic stroke. Let's separate, and now we can ask a prediction question, which is, amongst people who start anticoagulants, which one of them had one of those hemorrhagic strokes in some period of time that we're interested in? So our framework that we have created is splitting up those pieces into logically independent units and then bringing them together in the composite form that's needed to answer the specific research question you have. All too often what we've observed, and particularly in the literature, is these things get muddled together and conflated. So more often if someone was like a SAS programmer or something, they would start by creating a data set which is like a row per person in a target population, and then they're just creating a variable that's like a flag, yes or no, did they have the outcome? But now baked into that data set is all those decisions about how did they define the outcome and what was the time at risk, and it all got synthesized down into that binary yes-no variable. We're trying to make all of those decisions and choices become explicit elements that you integrate as part of the process. Yes, Christoph?
Does the machinery we're looking at today only allow a binary outcome, or do we have a continuous variable that we're trying to predict?
So the framework that you're going to learn about today is for binary outcomes. Yeah. Okay. So Jenna put up this slide, and you got to read these questions quickly yesterday as you went through the example. But I want to put it up here again, and I'm actually going to leave this up here as we work through the handout that Ross just passed out. These are examples of types of prediction problems that we could think up, but what we've recognized and what has been exciting for me about this framework that Peter and Jenna have been leading is that we've realized that there's lots of different types of questions that can be answered using the exact same consistent framework. And so, disease onset and progression, it's very often we want to say, amongst people who have some disease, what bad thing happens to them later? And you could insert kind of any disease and any bad consequence, and that is a very valid and useful prediction problem. You saw actually yesterday in the work of Legend that treatment choice is actually really, really important. Amongst people who are eligible to consider treatment A or treatment B, which choice do they make? And so when people talk about propensity score, that is nothing more than a predicted probability that one could apply a prediction model for. Treatment response, it's quite often we might want to say not just that warfarin causes bleeding, we know that's a causal effect, but we'd like to know which patients who initiate warfarin are going to have a bleed. We think about treatment safety, but you can also think about, and to Christoph's question, as long as you can create an outcome that is a binary indicator, something discrete happens at some period of time, that will fit in the framework. So an example of treatment adherence, adherence may be a continuous value of what your proportion of days covered or whatever, but you can dichotomize that to say, is someone sufficiently adherent in some unit of time? And that's available to you. The reason to emphasize that there's these different types of problems is you're going to learn one generic framework today, but we hope that you'll find that one generic framework will allow you to solve a lot of these different problems. So the exercise that we want you to do, you have a handout in front of you, and it basically asks for you to right now define a prediction problem. I want you to just basically write down on this piece of paper what's your T, your target cohort, what's your O, and what's your time at risk. The model specification piece is kind of a secondary consideration for the purposes of this conversation. But the questions that we often will ask someone as they are thinking about a question is, what would you expect the model outputs to look like? Are you expecting your prediction problem to be predictable on the basis of the type of data that might be available? And if you did have a prediction problem, or we did learn a model for your prediction problem, what would you do with it? How are you actually going to improve the lives of patients with that model? So I want you guys to take 5 to 10 minutes right now to fill in this form in front of you, come up with a prediction problem. And I'm going to put the screen back on this just as motivating examples. But for each of you, I want you to just come up with one problem that you've got in front of you. And we're going to be using this immediately thereafter. So everyone's got to do it. Take 5 minutes and fill out this form right now. Okay, good. All right, exercise number 2. Exercise number 2, you guys are going to create teams of 4 right now. and you're going to share your prediction problem in groups of 4 with each other. And your task is specifically amongst your group of 4. I want you to hear about each of your 4 questions and share your problem. Talk about if it sounds like a well-specified problem, if it's clinically interesting. And amongst your group of 4, you have to vote on one that's going to come out of your group as a possible question that we're going to solve today. Okay? So, let's see. How about you? Well, should we do it by rows? We got. I guess we could do rows. That probably would work. Why don't you guys? Your teams are your rows, but you might want to congregate or however you want to do it. So we're going to take 10 minutes. Please read your question to those around you, and ultimately I'm going to come back and ask which one question are you saying is the best one from your group. All right. You all came up with your own question. Hopefully you had some time to socialize your own idea, so get a little bit comfortable with this framework of asking this prediction question. And from that, you got to hear not just different perspectives and different problems, but hopefully motivated to come up with one amongst your group that you think is the best problem ever. So I want to hear what those problems are from each of the groups. So could someone in this group start and tell us what was your T, what was your O, and what was your time at risk?
Yeah, so we thought about our discussion. So I like the proposal.
Do we have a hand mic?
On diabetes, there were 2 ideas of do something with a cohort of diabetes patients and look for some outcome, but we went for something that we thought was straightforward.
Okay.
Was people starting. Thanks, Peter. So we started with. We'll start with people having traumatic brain injury.
That's the target?
That's a target population, a cohort.
Traumatic
brain injury, and we specified it further that they should be in hospital, because there will be many traumas undetected in the population, but we are starting in hospital, though they have a CT scan that might be further precision of that. And then we would look for the outcome would be mortality.
Mortality, okay.
So a simple hard endpoint.
Okay.
And time in current studies is often 6 months, but we could go longer. That would make it more exciting because there's less known about long-term outcome.
So in 6 months is from the time of the start of having a traumatic brain injury?
Exactly. So well-defined starting point, trauma before you were well, then you had a car accident or you fall in elderly, that sort of thing.
Perfect. Great. Thank you, Yvette. So we got one problem that might be the best problem ever. Group 2. What is your best problem ever?
Similar, we talked about several different problems, and I think there's some question around. Several of us aren't clinicians, so we're not quite sure exactly what was medically relevant. But I think we were going to present this problem that was presented by the clinician I work with, which are among patients newly diagnosed with Graves' disease, who will go on to develop Graves' ophthalmopathy.
Thank you. That's why we got a clinician.
Exactly. And the time at risk is 18 months because I guess there's like a fairly high probability over that time period, 80% or something like that.
So 18 months from, and this is initial diagnosis of Graves'?
Yeah, which, I could imagine that being, not a real great concrete boundary there. But.
Okay, good, very good question. Maybe it's the best question ever, we'll see. Group 3, what's your best question ever?
So we had 3 completely different questions, and so the only way we could come up with a decision was we drew lots. And the one that came out was looking at it's a medical device question, and one of the things is for people who have severe arthritis of the knee, they get total knee replacement, and there's a risk of loosening of the prostheses in the what that's inserted, and then the patient has to have a resurgery and take out the old prosthesis and put in a new one, and that's quite a traumatic surgery. So our goal is to look at predicting the occurrence of aseptic loosening in people who have had knee replacement surgery.
So people with knee replacement, so the target is people with knee replacement. And the O is aseptic loosening?
Yeah. aseptic. That leads to resurgery.
To resurgery. Great. And what's the time frame for it? What is your time at risk for that?
Well, once a patient's got it, it's like till they, it's indefinite until their length of their life, really. The exposure never goes away.
But what would be so for a prediction problem, you need to define a time horizon that you are going to be
10 years,
looking for.
so 10
10 years? Okay, great. 10 years from the day after the surgery?
Yeah.
Okay. From surgery to 10 years later. Very good. That might be the best prediction question ever. We'll find out. Question group 4. What is your best prediction question ever?
Okay, so since it's another flu season now, so we are thinking, so the target cohort should be the patient or people who receive flu vaccination. And we're interested in, since I read some of the literature and saying that it's a very rare adverse event for the flu vaccination is that some of the people develop GBS syndrome, which is a very severe neurological disorder.
Yeah.
So we're interested in prediction of people who receive flu vaccination who develop this.
Guillain-Barré? Yep.
Yeah, that's right.
And so what's your time at risk?
Maybe, I think a reasonable follow-up time should be like 1 year.
A year? 1 year? 1 year from the time that you get the vaccination?
Yes.
Okay, very good.
Okay.
That might be the best prediction problem ever. We'll find out. Group 5?
Yeah, we had a lot of good ideas. We were fortunate enough to have a gastroenterologist on our team. So we also were sort of looking at things that would be amenable to an analysis using claims data. So we decided to look at, in terms of a target population, patients initiating NSAIDs with osteoarthritis.
Yeah. Okay, so that's your target group, initiated an NSAID for OA. Okay.
And our outcome is gastrointestinal bleeding.
GI bleeding, very good.
And our time horizon is 365 days after initiation.
After initiation, perfect. That might be the best prediction problem ever. But let's find out. Okay. The back row there.
Here's the
The
mic.
sticky ones.
Our group, the target population, the people who smoke, so a past smoker, a current smoker, and we're interested to predict who are more likely to develop lung cancer. Yeah, so the time at risk when people start to smoke, so because the cancer take a long time to develop, so our time at risk, we hope to predict in terms of 20 years window.
So more specifically, your target cohort is actually people who start smoking.
Yes.
Because you need to know that start of the smoking
Yes.
to use your time at risk, and you're looking for 20 years after starting.
Yes.
Okay, very good. That could be the best prediction problem ever.
Thank you.
Maybe.
We hope.
Next row.
Our group's prediction problem, the target cohort will be those patients get advanced non-small cell lung cancer and treated by pembrolizumab.
Pembrolizumab.
Yeah, Keytruda. So the initiation date will be the index date, and the outcome cohort will be patient who get progression or death.
Progression of the lung cancer?
Yeah.
Okay.
The time at risk will be 24 months from index date. That makes sense?
I'm sorry, I just missed that. Time at risk would be what again?
24 months from index date.
24 months?
Yeah.
Got it. 24 months from start. Okay,
Yeah.
perfect.
So the covariate could be LDH, ECOG, BMI, age, smoking status, something like that.
Got it. Those are
Yeah.
your predictors? Okay,
Yeah.
perfect. Very good. That might be the best prediction problem ever. Next group.
So the context of our problem is that a large fraction of people with bipolar disorder are initially diagnosed with major depressive disorder and potentially given inappropriate treatments like antidepressants that could make them manic. And so the target cohort would be patients with greater than 1 year of no prior diagnosis of major mental illness, newly diagnosed with major depressive disorder.
Mm-hmm.
And then the outcome cohort would be subsequent bipolar diagnosis, and we're saying within 2 years it could be changed, but that's a reasonable.
No prior mental health. So basically, newly diagnosed with major depression.
Yes.
But then, in some period forward, they get a new diagnosis of bipolar. Beautiful. And the time at risk again? I'm sorry.
2 years post.
2 years.
Post that.
From
first.
the MDD
Yes.
diagnosis. Good. No mental.
And I would throw all covariates that we can at it.
Perfect. That is a great prediction problem. That might be the best prediction problem ever, Christoph. We've got one more to find out. Next group, Pavel.
Okay, so our group want to find the target cohort should be newly diagnosed breast cancer patients.
Okay.
And then the outcome cohort should be recurrence of the breast cancer again. The same
Recurrence.
breast cancer, yeah.
Okay. Of the breast cancer.
Yeah.
Okay.
The same kind breast cancer.
Okay.
And then 2 years later.
2 years later.
Yes.
Very good.
So your index 8 is the completion of the treatment of breast cancer or the diagnosis of breast cancer?
So that's what we are concerned. So I don't know exactly, after chemotherapy or because I'm not clinician, so I don't know exactly.
Or without hormone therapy as well? Hormone therapy plus.
So operation, chemo, and hormone therapy. So this chemo and hormone therapy can be covariates or just like we can include to our target cohort.
So, yeah, this is actually a great question, which we'll get into a lot in the framework, but part of this is when you think about a prediction problem, you only get to use the information that's happened in the past to predict the future. So if you are newly diagnosed with breast cancer, treatments happen after the diagnosis. That means you can't use those as part of your prediction.
Okay.
But you could say, after you've finished your initial round of treatment, then predict who's going to recur, in which case your index date becomes at the completion of the therapy.
Completion of the treatment. And then 2 years later, the recurrence of the breast cancer.
That's right.
Maybe that's the best. Better.
Very good.
Yeah.
Great. Excellent. Okay. So, Chan, if you want to hold those up. So that was an excellent set of questions. One of the reasons we do this exercise is for you guys to get familiar with just this idea of thinking about prediction problems, and also to recognize that you now have lots of good questions that all fall in this exact same framework. And as you will learn the tools, basically, whether you are interested in people with lung cancer who go on to have progression, or people who have traumatic brain injury of death, that everything that we're going to cover today is going to be equally applicable for that. But we got one more exercise. You can't all have the best prediction problem ever. So now that you've heard the questions and you've heard the motivations, we are going to vote on which one is truly the best prediction question ever. But there's a twist. Not only do we need to think about whether or not you think it's a well-specified problem, not only do you need to think about whether or not this is clinically impactful and would be useful, but also we need to think about whether data are going to be feasible to allow us to do this. And so when we think about data feasibility, there's going to be a couple aspects to that. One is, can we create an operational cohort definition against observational databases to define the T and the O? And some of these are probably going to be easier or harder than others. Data feasibility is also, though, about whether or not we expect the data to be available. So, for example, pick on Avad's question there, like one of the annoying challenges in US data is that death is actually not fully captured in most US data sets. So even though that should be the absolute easiest outcome intuitively, it turns out that it's hard in the US. Now, Chan's got access to national Korean data for which that's perfectly captured, in which case that would be an example of a question where maybe infeasible in some data sources, but a tremendously good feasible question elsewhere. Okay, so you've got this list. I'll just go through them again. Everybody's going to get to vote once here, okay? So think, yep.
You're not going to inform us further, because I would really like, for these three aspects, if you could say something like, okay, this is easy and this may be hard or in between.
Do you want me to give my biased opinion?
I would, because otherwise I'm just...
Okay. Okay, so I will provide a biased, my own biased perspective based on what I know. I have a little experience. Okay. So, so first question, hospitalized traumatic brain injury and death. I think we can find traumatic brain injury in most claims in EHR systems. Death is going to be variable across our data. Initial diagnosis of Graves' disease and ophthalmopathy. I can't pronounce that one. I've never looked at that in my data. I suspect, though, Graves' disease is pretty rare. And so I bet you it's a good, clean clinical diagnosis, but it might be the kind of target population that's small. Doesn't mean we can't do it, just means we might be limited in what we could do, given the size. Looking at knee replacement for osteoarthritis, certainly we see the procedures of knee replacement. That's not a problem. Looking for aseptic loosening, it's likely going to be that we're going to have to use the resurgery as the proxy for the outcome in that case. You won't actually know why they had resurgery, but you'll be able to see the resurgery, though Paul would know a lot more about how precise those codes, and Eric would too.
That's 10 years of the time at risk.
Very good point.
That's going to be an issue, like 10 years of observation of that, so it's not available in each dead source.
Thank you, Paul. That's very, very, very perfect. Yeah, so when we think about the follow-up of a lot of databases, it is highly variable across the community. But if we're talking about like a US administrative claims database, we've got like an average follow-up of like 2 or 3 years. If we've got some of our European data that are more extensive covered, you know, like...
This guy's those exceptional.
Yeah, so like, you know, like our friends in Denmark who have birth to grave, that's really nice. We've got longer term data, but certainly the longer time horizon you go, the more challenging the prediction problem comes. So I would think doing knee replacement and resurgery is possible. A 10-year horizon might have to be shortened based on the data that's available. There are people who have converted the CMS Medicare data to the OMOP common data model. Does anybody in the room have access to it? So nobody in this room has access to it. So it could be done theoretically, but you are not here to get a theoretical tutorial. We are solving clinical questions that matter to patients today. So, yes?
Do you have to have 10 years follow-up on each patient to have that, or however long you have?
Great question. So just to repeat for the camera. So do you have to have 10 years on everybody? We're actually going to go through the parameters of that, and that's a conscious choice that you have to make. Do you require everyone to have complete follow-up time, or are you going to allow someone to have incomplete follow-up time? That's a parameter, and it's a choice you have to make when thinking about the modeling. All right. We can see people who get a flu vaccine. Guillain-Barré syndrome is extraordinarily rare. It is diagnosed. It is a diagnosis code, so you can see it, but it's pretty rare. But could be done. Patients who take NSAIDs for osteoarthritis, we got lots of NSAID use. People who have GI bleeding. GI bleeding has been studied exhaustively. In a year horizon, that's a feasible question.
Regarding the previous thing, again, this limitation, I believe you need to have more or less enough of outcomes to properly train your model. If you have, like, I don't know, 10,000 of people in target cohorts and 5% in outcome, this won't work.
Yes, so, yeah, one of the things that we will go through is how you can actually quantitatively assess feasibility just by looking at how many people are in your T and how many people are in your O. In this case, like flu vaccination, like at least in the US, a very, very large target cohort. So even if the incidence of GBS is rare, which it is extraordinarily rare, you still might have enough cases to be able to look at that. It's possible. But I haven't actually looked at, you said specifically this flu season. I don't know whether we have enough in one flu season to be able to detect that. Christoph?
Also on the NSAIDs, a lot of it's over the counter and won't be recorded.
Yep, that's a really good point. Yeah, so when I didn't write it down. I heard prescription, but yeah, absolutely, it's a very good point that the Advil that I just took was not recorded in any EHR system. So you do have to think about that and be more specific about our target. Patients who start smoking and go on to lung cancer, I would actually say this is actually going to be classified as an infeasible question. Most data sources are not going to tell you when someone started smoking. In fact, most data sources don't even adequately capture smoking status at all. Do you have when they start smoking?
Yeah, in claim database, in Korean national claim database.
When they start smoking.
The history of smoking.
If they're a smoker, yeah. So sometimes you see in the data that if they're a smoker, but specifically requiring that we need to have start smoking, that's going to be a pretty substantial limited problem there.
Probably operational-wise, you could say if we haven't smoked, the databases haven't seen the smoking history in the past year, could be as a surrogate, say maybe they are new onset.
Yeah, so you could try to create some sort of a proxy. It is quite likely with a social behavior like smoking that's going to be a pretty rough proxy. But you're absolutely right. You could think about how to try to create something that's might be good enough.
But isn't this already proved, question? Smoke and cola same as asbestos.
This is a great question, Pavel. So you just said, isn't this already proven? This is actually a really important point. What is proven is the population level effect estimate, that people who smoke, smoking causes lung cancer. But we're not answering that question in this class. We're saying amongst the smokers, which ones are going to get lung cancer? So that's actually not a causal question, and it actually doesn't matter whether smoking does or doesn't cause lung cancer. You're rather saying, if you are in this group of people who are at risk for lung cancer because you smoke, which ones are going to go have lung cancer? Because not everybody who puts a cigarette in their mouth gets lung cancer. Some people do and some people don't. And the question becomes, well, is there some other predictors that would tell you that you're more or less susceptible for the disease?
Just to support that point, I think that in the current era, there's a lot of discussion about lung cancer screening, and then the whole issue is who to select for screening, which would directly motivate such a model.
That's right.
So there have been quite a series of models out there that have been validated recently, and I've been involved in one. But to repeat that in this context would be a great question there, I would think. So you should say, I think target is smokers, and the characteristics is smoking history in a broad sense. So it includes starting age, perhaps, with back years, and all these kind of things come up then.
So if this was just people who smoke, that changes the target. It changes the question a great deal, because you're now not looking at time until from smoking to lung cancer. You could think about just smokers. If we were, though, to have a target cohort of smokers, we do need to still have an index date, because it has to be a moment that you were doing a prediction. And so I support the idea, but for example, we need to be more specific. If it's smokers, it's going to be like people who had a visit, and on that visit they had smoking status recorded as yes, in which case anybody who goes to many visits probably has that happen. So then you have to be more specific and say, probably, let's find the first time that smoking status was marked as a yes, and then you have to think about what does that population actually represent. So I support the idea, but there's a lot of nuance that the reason we formalize this idea that you have to create cohorts is you got to have an index date. That index date, you can use the data before, but you can't use the data after. And so temporally positioning this is very important. Yes?
There's some things that we found that are just the measurement error too around this diagnosis. So usually I'm just thinking maybe like MS or something like that process of diagnosis.
Yep.
You're getting people that maybe are diagnosed very early with the disease later with the disease,
Yep.
but they're all suffering, they all have the disease over
Yep.
the same time period. I don't know, does that make sense?
Yeah, so there's two types of measurement error that we're going to have to pay attention to. One is that for each of these T's and each of these O's, there could be misclassification. Someone who has a code for lung cancer doesn't actually have lung cancer. Someone who has lung cancer doesn't have a code. So there's that kind of misclassification. And then there's a second dimension of misclassification is the date that we assign someone could be the wrong date. So the date that they get a diagnosis of lung cancer isn't the date that they got lung cancer. And so we have to be sensitive to those two types of misclassification. For patient-level prediction, what we really are predicting is amongst the people who belong to this target cohort, which of them go on to belong to this outcome cohort. So that's kind of subject to all the noise. It should probably be expected that if there is error in either the classification or the timing, then that would mean that your prediction would do worse than you would have otherwise done if you had clean data. So if we get a good model, despite the misclassification, we actually can say like we did well given that problem absolutely is true. All right, lung cancer with Keytruda and looking at cancer progression. Just defining cancer progression is an extraordinarily difficult thing, particularly in administrative claims in electronic health records, because very often you see kind of a continuation. It's easier in like free text notes, but in terms of the coded structured data, cancer progression is a challenge. Death you could do. The cancer progression is a bigger challenge.
When does it introduce in US market?
It's been on for a couple of years. So it's cancer with this drug. We might not have a giant target, but like it's a population that could be created. What's that? Does anybody in the room have Flatiron and CDM? No, I mean people do it, but I just don't know if any of you guys have it.
What's that?
Information from the free text is actually within the authority report or predominant report.
It's a non-cancer, it's cancer data.
We are trying to convert our reports from radiology and pathology into CDM, but we have not.
Not there yet.
Yet.
All right, 2 more questions to go through, and then you're all going to get to vote. Major depressive disorder with no prior mental health, predicting new diagnosis of bipolar. I think this is a very clean and straightforward problem that could be done in administrative claims and electronic health record data. And so that's in a 2-year horizon, it's very reasonable to do this problem. And then the last one was newly diagnosed breast cancer, or after the index will be after therapy completed, and then look for recurrence.
Can I clarify? People who went through treatment for breast cancer went out disease-free should be the target.
Say it again.
People.
Patients which went through breast cancer treatment and came out disease-free.
Yeah.
Got it.
So, to my knowledge, usually hormone therapy continues at least 5 years. Right now will change, but currently it recommends to continue the hormone therapy for 5 years. So if the patients have the hormone therapy for 5 years and do not have any other therapies after that, it means that he will or she will complete the therapy. So
Got it.
It can be your index date
After that 5 years.
After that 5 years.
Got it.
What? Clarify, you misstated.
On the prior one, no prior major mental illness, which is bipolar, schizophrenia, schizoaffective, and major depressive disorder. So we're not saying no prior mental illness. We're saying none of the biggies.
Thank you. Yep. Very good. So the challenge that I've experienced in using particularly like U.S. administrative claims, things with cancer and recurrence is really challenging, particularly because there's a lot of follow-up care, and the follow-up care will be recorded as the justification for it is because you previously had breast cancer. And so teasing out continuity of episodes of care from a new onset is a challenge in U.S. administrative claims. In electronic health records, I see it pretty nicely in the free text, but it doesn't always go from the free text into the structured data very well. So in my perspective, the recurrence is a challenge. You can create clean proxies, but very often, to make it clean, you are losing a lot of the legitimate recurrences that are just muddled in the data.
I added something because we posted a poster yesterday about the same problem. So So it was the epidemiological studies that's looking for recurrence of the breast cancer in the breast cancer patients. So if you are interested in this topic, please let me know, and we'll pose this problem to the forum. And
Perfect.
Please.
So yesterday you should have been impressed that we took a question that was asked by the audience and we answered it by the end of the day. Now we've taken a question you asked today and answered it yesterday. So just think about that for a second. Only Chan could pull that off. Okay. All right. So you all get one vote. Okay. And we're gonna tally, and I'm gonna first tally on this sheet, and then we'll grab that one. Okay. So you all got your votes in mind. All right. How many people want to do smokers' lung cancer? Raise your hand. Raise your hand high so I can count them, because we're counting. 2. All right, 1, 2. Great. How about lung cancer, Keytruda cancer progression? No. No.
Change the outcome to death. Will that change?
Change to death. Does that change your votes? Anybody want to vote? No. Okay. Major depressive disorder, no major mental illness, including bipolar or schizophrenia, and looking for that new diagnosis of bipolar. Well, we do not need to vote anymore. Christoph, you have the best prediction problem ever. Yes. All right. Well, that is I think that is a extremely well specified problem. That is something that we could absolutely feasibly do in data. Could feasibly construct, and I think we are going to solve that today. So, great. So thank you guys for going through this exercise. Now you're going to learn how we are all going to solve that problem together.